and welcome to Endo Bites, Bite in Time, our short format podcast series where we discuss timely developments in endocrinology and metabolic health. I'm Kate Glasenapp, assistant professor and nurse practitioner in the Division of Endocrinology and Molecular Medicine here at the Medical College of Wisconsin and co-director of our medical weight loss program. Today we're discussing a topic that almost every clinician treating obesity encounters: what happens after the weight loss? As the use of GLP-1 receptor agonists and GLP-GIP receptor agonists continues to expand, questions about weight plateaus, long-term maintenance, discontinuation, and off-ramping are becoming increasingly common. So joining me today is Dr. Srividya Kidambi, who is our professor of medicine, chief of Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin, and co-director of the Medical Weight Loss Program. Her clinical and research interests focus on obesity, diabetes, and cardiovascular risk reduction. Dr. Kidambi, welcome back.
Thank you, Kate. Well, this is our last episode in this series.
And it's a lot.
Yeah, it's a lot. So let's see how this goes.
Weight loss medications have really transformed obesity treatment. And there's so much coming in future years. We can see that. However, many patients eventually reach this plateau. So what are those plateaus about? And those plateaus can happen even when patients are still on therapy. So What is that?
Yeah, so, I think we are in this unique place in our, even just about a decade ago, we never thought we would be here.
Right.
Our patients being unhappy after 10, 15% weight loss, right? I think, and there is unending urge to keep losing more and more weight. I think, before we even address plateau, I think we probably at some point during the journey have to talk to the patients about what is the expectation from these drugs. I think that's a conversation we probably don't have. I explain to them, but somewhere along the line, I don't emphasize, this drug causes 20% weight loss. What does it mean to you? And things like that. So I think people have seen someone else lose 100 pounds and that's what they're expecting. And they're not happy when they stop at that 20% or 15%. Now, many things happen, reason why either plateau or maybe subtle inching back up. One is that when we lose weight, we are not really losing just fat mass. We are also losing some muscle mass, which consequentially decreases the resting metabolic rate. So at some point, the amount of food intake reduces and the patients lose weight. So there may be, at some point you will reach like a steady state where the amount you're burning is probably equivalent to amount of food you're eating because you're burning less calories, you're eating less, but that's just maintaining the weight. Sometimes the hunger might come back. I mean, the tolerance is a thing with all the weight loss drugs, right? So after a while, your body kind of gets used to it. And so you may not really be feeling as much hunger suppression. And they ask me then, change to that or this. I mean, we can certainly do that, but I think there's only so many options that we have to further decrease the appetite. I think should not be the goal. The goal would be how to increase your activity and maybe get some the proteinaceous food, good, so we should not really forget the lifestyle modifications. Now, in general, the diet-induced weight loss always resulted in definitely some metabolic adaptations that resulted in this resting metabolic rate decrease, as well as some changes in hormones. Which is increase in ghrelin, which is a hunger hormone, decrease in leptin. So the weight loss drugs fight against some of that. So that's why we are able to, unlike diet-induced weight loss, where after 3 to 4 months people gain back weight, we don't see that weight gain back. We just see the plateau. So some of those hormone changes are still are happening. And also there is some metabolic efficiency. So your body actually, even if you're active, it may actually use less calories to do the same kind of activity. So in all, if you're actually maintaining a plateau, it's a good thing. It's not necessarily a
Yeah.
bad thing. I always try to say, do other things, adding more activity, modification of food, go back to the dietitian and things like that. So,
or change your activity. If you're doing one thing, change it up a little bit, introduce something different. And so it sounds like that conversation is when the patients hit the plateau, you often hear this medicine isn't working anymore. And that is not accurate.
That's not true.
Yeah.
I mean, if the medicine wasn't working, you would actually gain back the weight. So medicine is what is keeping you at the plateau rather than,
Yeah. So, and that is a common question. So do I need to stay on these medications forever? So what does happen? What do we know when the GLP-1s or GIP agonists are discontinued?
Yeah, so we talked a little bit earlier, but I've almost on all the studies that specifically looked at this question, both for tirzepatide and semaglutide, have shown that about 2/3 of the weight loss that was lost is gained back at the end of 1 year. So, so my opinion is that these are long-term medications. We are not stopping them. Now, does it mean that everyone has to be on the same dose? So we can talk about some other off-ramping or maybe reduction, but I think our patients need to understand that they do need to stay on them for long periods of time. Now, our insurance may be one of the issues. However, the drugs cost might be coming down, so the insurance issues hopefully will resolve. At some point, like the statins, I'm being told by my older colleagues that things were similar with statins, which were so expensive at one point, and so we don't even blink an eye right now. No one even talks about stopping a statin. So these drugs might become something like that. So these are long-term treatments, and maybe there are. We talked a little bit about our new friend or forglipron, or some other oral drugs could become, weight maintenance type of thing, maybe not the injectable one, although injection doesn't seem to be the biggest hurdle that most people face. So I think for now, for all of the people, in some form or the other, the obesity treatment should probably exist if that's the reason why they started.
Okay. And it may just be that a matter of time if we think about it, even obesity as a diagnosis is relatively new to recognize it. So recognizing obesity as a chronic disease that requires chronic management. And so that will hopefully drive the insurance industry. So now, despite their effectiveness, this was surprising to me that many patients stopped treatment.
Yeah, so so we did know that, I think those of us who are practicing, there was lots of starts and stops, mainly because of insurance and unavailability. And so the data that were published better part of last year were really looking at retrospectively, people that were in those, lean times for GLP-1s, like, 3-4 years ago. So the data that we have right now, even the ones that are talking about this 50% discontinuation rates, really comes from that cohort of people. So it may not be now. If you publish the data from this time, 2 years from now, that may be different. But having said that, but that's what we know in real world studies. One large cohort, again, all of the studies were kind of internally consistent. There were several small studies, and this one huge study, above 125,000 patients of retrospective analysis, 54% discontinued GLP by 1 year and 72 by 2 years. So the discontinuation rates were higher in patients without diabetes. That is 65% at 1 year and 84% by 2 years. Now, that could be because a lot of these were self-pay patients, or the insurance was not covering for obesity. So it could be that they didn't specify, but the discontinuation rates were higher in patients who were taking GLPs for obesity. That all the other reasons were cost, insurance coverage, medication shortage, GI side effects. Again, the GI side effects issue was kind of shown in the trials, where the discontinuation rate was about 6%. So, many of them, almost like literally every trial, somewhere between that 5-10%, and we are seeing real world 54%. But that is something that's not really GI side effects. The other things is that unrealistic expectations. Well, they're not, it's not working for me, right? So the other, so the study also looked at who went back. So those who had, again, diabetes went back to the drug. Obviously, diabetes must have gotten worse. Or those who had early, really good response, and then for some reason they stopped it, whether it's cost or insurance, those are the ones that were able to go back to that. So again, nothing surprising. It's not, you know, these are all the things that we have experienced and seen. This is more kind of putting, okay, you know what, this is really the data. So it's not just my own personal experience. So yeah, I mean, I'm looking forward to seeing what studies will come up sometime next year for retrospective studies to see what the continuation rates would be.
And I think too, as you mentioned before, setting those expectations.
Yeah.
So if there's side effects, do we need to stop the metformin? Do we need to review lifestyle strategies that will better tolerate it? So the more we know, the more we kind of caution about that. And do you think there's a certain subset of patients that would be successful in maintaining this weight loss? So is there, in terms of when you look at the regain, is there a population that has better success with that?
So there's no way to predict who can stop therapy and who can maintain weight loss. Again, my standard line is that you need to continue to take the medication. So, however, there are a few that stopped on their own and they come back and they're maintaining it. So again, I just have to speculate what it might be. So people who have regular physical activity, resistant training, higher protein intake, consistent meal pattern, self-monitoring, and follow-up. Again, you know, these are not any strategies that has been prospectively validated as in the post-GLP-1 setting. So it's impossible to say, you know, now, you know, patients who have had already very high BMI and, you know, binge eating patterns and those things. So these are the people perhaps will gain back weight. Again, there's no way to predict. So
I think if there's if a patient comes to you and wants to stop the medication, how do you counsel them?
Yeah, so you know, I would say again, my standard line is don't stop. So now, what is it? Why do they want to? Right? Is it the cost? Is it the side effects? Are they planning pregnancy? Just tired of taking medications, insurance issues, and stuff. So it depends on all of those, right? So then you have to address that issue specifically. Now, if they want to stop because they have gotten great effect, you know, that's the reason they want to start. They don't want to lose any more weight. Then I would suggest doing off-ramping. Now, if it's cost or even side effects, some of these strategies could work for them too, right? So obviously, right now, the medication costs are a little bit variable. The insurance, that's a different story. If they're self-pay patients, there is a issue with so the oral drugs are a little bit cheaper compared to injectables. So could you adjust some of that? Or you could do microdosing, which is a thing now. So again, you can only do microdosing with semaglutide, Ozempic version of it because it's a multi-dose pen. You could potentially do that. You could also extend the duration of in between. So again, there is nothing that says that you have to take this drug every week or again, none of this is FDA approved. It's completely off-label, what we have figured out by trials. So is that when you can take it infrequently as long as you don't have side effects. So I try to tell the patients, start taking every 10 days and then you can make it to 11, 12, you know. So because the reason that you want to take it at certain intervals is that you don't get side effects, right? Because if you take it once in 3 weeks, the same 15 milligram dose of tirzepatide, then you'll get really nauseous and have side effects. So you have to figure out what's that interval for you is. So you could do 10 days to so I asked them, hey, you know, if there was there any time frame that you were, you know, you could not fill the medication, and what was the duration? So yeah, you know what, there was this one time I couldn't fill it, and I had 2 weeks, and I took it, and I had no side effects. I would say, oh, okay, 2 weeks is your thing, right? I mean, I typically go no more than every 2 weeks. So somewhere between 10 to, so that would, if they're buying out of pocket, that could be one way to give them, especially if it's a tirzepatide, you cannot change the dose. You could do it once. And so if it is Ozempic that they're on, then you could microdose by click count. I also add, so for side effects, I also look at what are the other drugs that they're on. So it's not cost, it's not anything else. So often we combine metformin with these drugs. And so combination of metformin with the drug could result in some side effects.
Sure.
So I would say decrease the metformin because these are more effective than metformin. So then see how you're able to tolerate. Now, when I'm doing microdosing to reduce the cost, I add other drugs to kind of get that effect. So I might add, if I'm only giving 0.5 or 0.75 of semaglutide, I might add metformin to that. And I sometimes add intermittent phentermine therapy to kind of get that, keep the low dose GLP-1 going, but add other drugs or sometimes topiramate or Wellbutrin. Some of these are all off-label, uses. You have to be very, very careful who you select those. I mean, they all have a lot of side effects and a lot of contraindications. So this is, you have to be seasoned provider to use those combinations because otherwise we don't want to cause more harm than good. So those are some of the things that we do.
Yeah, and I think that illustrates the, what experience does. This is not as easy as just writing a script and sending the patient out the door. This is really anticipating that they may want to stop the drug and what else is there. So are there branded anti-obesity medicines that you combine with GLP-1 drugs? Is that something you
so all of them are complementary. There is so obviously the DPP-4 inhibitors, that's one class of diabetes drugs you don't combine. It's not approved that way. So all of the GLP-1s you could combine with topiramate. You could combine with metformin. Again, those are all don't have by themselves weight loss indication because for a drug to get a weight loss indication, you need to have 5% weight loss after at the 3 months. That's how the drugs get weight loss indication. But if you have 3 to 4% efficacy, and if you have a low dose GLP-1, as long as they tolerate, you could add those. So I use Qsymia, which is the topiramate phentermine combination. Some people Contrave, which is a Wellbutrin naltrexone combination. So you could use generic versions of phentermine or topiramate or Wellbutrin added to one of these drugs. Now, some of these, they are antidepressants and they may be on other psychotropic medications, so you have to be careful. So now they're not contraindicated from each other. So we have to be careful who they are and what is the background so that,
And you also had mentioned in a previous segment that orforglipron may have a key role in maintenance. So that's something to keep in mind too.
Yeah. So 10% weight loss maintenance, again, cost, if that is, so I think right now it's still cost prohibitive compared to some of the other drugs, but that could be. The other thing that we haven't talked about is that, again, one more time to take a look at, this happens that even before you should put patients on any of these drugs, is what other medications, obesogenic medications that the patient is on, which is very important. That's a different discussion. So again, maybe when I have a plateau, then one more reason, sometimes, it only causes 3-5% weight gain. I may have just, maybe it's easier. So if they get a GLP-1, maybe that's kind of offsets. But when you are, when you're in a pinch, you need to take at all the strategies, beta blockers and whatnot.
And can you just briefly address the role of lifestyle interventions in weight loss maintenance?
Yeah. So, I think we kind of forget that. It's, it is hard to do that, right? So to do the counseling for weight, diet and exercise, but I think you must say, I used to, back in the diabetes, when I used to do a lot of diabetes and, I would, fellows would be around and, every time you would ask, And every time you would, about diet and exercise, every time they go out, you would still, they haven't done it in the last 5 years that you've been talking to them. However, there's one day it clicks. So, right? So I would tell them, like, still, you have to still do it every single time, because it could be, there would be one time that they would. So I think you have to do that. And, it's not just for weight loss or weight maintenance. I think just the activity increases longevity and mood, irrespective of whether there's weight loss or not.
So it's the nutrition, it's sleep, it's stress management, the exercise piece, all of that. So do you have any comments on compounded medication? Do you want to mention that briefly?
Yeah. So, that hopefully, at one point FDA said it was okay when there was so much shortage. I think we have given a little bit of mixed message about that. I go by the book, and well, it doesn't appear so, especially I talked about so much off-label use of these different drugs. But in general, the compounded drugs are not regulated. It's like any other compounded therapy. So, the people that are also, in the practices that they're doing that, sometimes I notice that they're not doing the due diligence. It becomes like, okay, I'm going to write a prescription and off you go. And they're not cheap either. So actually, I am pleasantly surprised that they're very expensive now. So I think our FDA-approved medications are coming in. I think so what I tell my patients is that, right now the cost is almost comparable. So I would rather have you take a legit approved FDA regulated medication every other week or every 10 days than take something every week that I cannot vouch for, So I think there is a lot of dose. People, again, I'm very conflicted about that. I have seen some patients that come and they have lost weight with it. But I do my best to try to, have them take the one that's approved and that's being regulated. So.
Okay.
Yeah.
All right. Anything that you want to add? Anything that you've...
Well, I think we will probably be meeting another time to discuss, because there are new trials that will be resulting, and maybe new indications for existing medications. But we have triple agonists that are coming into the picture, some leptin analogs with the combination of with the semaglutide and tirzepatide. There are also some that are in combination with amylin analogs, long-acting amylin analogs. So they're all in the phase 3 trials, almost just about ready to publish some trials in the next 6 months to a year, and then more approvals might be coming through. Yeah.
So, well, thank you. Tremendous insights, not only in the medications, but the lifestyle strategies, and just as important is the relationship between the provider and the patient. That makes a tremendous difference. So thank you for joining us and sharing those insights.
Thank you.
So, and thank you to our listeners for joining us at this episode of Endo Bites, Bite in Time. And until next time, stay curious and keep learning. Thank you.
Thank you, Kate.